Hello, Holistic. This is part two of the presentation, Adjuvants in Palliative Care and Pain Medicine. We stopped last time at the NMDA antagonists. So this is a very important topic in pain medicine and palliative care. I'm sure all of you guys know that the ketamine and methadone are NMDA antagonists. But we have other drugs, such as dextromethorphan, which is an antitussive medication, buprenorphine, which is basically used in pain and addiction, amantadine, an antiviral drug, memantine, which is a drug that's used for dementia, and magnesium. All of these have NMD antagonism activities in different proportions. NMD antagonists are believed to prevent the development of opioid tolerance, helps with opioid addiction, and suppresses the development of wind-up phenomena, central sensitization, opioid-induced hyperalgesia, and has an important role in neuropathic pain. The most famous and most potent NMDA antagonist drug is ketamine or ketalon. Ketamine is a phencyclidine derivative that produces dissociative anesthesia. I want to say that if you are taking ketamine and you do a urine drug testing, it will show up as a PCP. Okay. The other thing is ketamine is metabolized extensively to norketamine. And the racemic mixture is the most available form in clinical use right now. Now, despite that, we have new, formulations of ketamine. Ketamine causes sympathetic nervous system stimulation, increases the salivary and tracheobronchial secretions, and can cause emergence delirium. Ketamine is metabolized by the 3A4 system to norketamine, which is, in fact, is a potent metabolite as well. This is basically the ketamine formulation and the ketamine for IV injection. Ketamine can be also administered subcut, and it can be administered intranasal. These are the NMDA antagonist drugs available in the market. The most important ones are the ketamine and the methadone for pain, memantine for dementia. NMDA and antagonist drugs play a role in chronic pain and opioid therapy. Basically, as we mentioned before, in drug tolerance, drug dependency, central sensitization, wind-up phenomena, opioid-induced hyperalgesia, neuropathic pain, and drug addiction. We're going to jump into another topic, which are basically the cannabinoids, okay? And we have two major cannabinoids, the CBD and the THC. In this slide, we compare the CBD to the THC. The CBD is non-psychoactive, while THC is psychoactive. CBD is neuroprotective. THC is a relaxant, muscle relaxant. CBD is an anticonvulsant, while THC is an appetite stimulant. CBD is an antioxidant, while the THC is an analgesic. CBD has an anti-inflammatory properties, while THC can cause euphoria and can cause paranoia. Recent studies suggest that cannabinoids can be useful for pain and spasticity. Cannabinoids interact with the body's endocannabinoid system through the CB1 and CB2 receptors. The CB1 receptors are located both peripherally and in the central nervous system, while the CB2 receptors are located in the peripheral organs and tissues. Dronabinol or synthetic tetrahydrocannabinol and nabilone are available options in the United States. Dronabinol and nabilone both have been approved for indications other than pain, but there is some evidence that they have analgesic efficacy. Nabiximols is a kind of cannabinoids not available in the United States. It's an oral mucosal spray that contains THC and cannabidiol. The most common side effects of these medications are dizziness, drowsiness, and cognitive impairment. These are the two formulations available in the United States, the dronabinol and the nabilone. Both of them are used mainly for, as an appetite stimulants in HIV patients and patients receiving chemotherapy. Okay, we're going to jump into another topic, which are the topicals. We have different types of topicals. We have local anesthetic topical, and we have non-local anesthetic topicals. Local anesthetic topicals such as IMLA cream, which is basically a mixture between lidocaine 2.5% and prilocaine 2.5%, formulated in an oily in water emulsion. Other local anesthetic topicals available in the market, are just lidocaine, dibucaine, pramocaine, butambine, and tetracaine. While non-local anesthetic topicals include capsaicin cream, which goes from 0.025 to 0.075%, capsaicin 8%, diclofenac patches, menthol, we talked about it in the first part of the presentation, methyl salicylate, and doxepin cream, which actually we talked about in the first part of the presentation. The lidocaine is one of the most common forms of topicals. It could be used as a gel or cream or even as a patch. The most famous one is the lidocaine 5% patches. You can use up to 3 patches, per day. The way you use it is you put it on the affected area for 12 hours, and then you remove them for 12 hours. The reason is lidocaine can induce tolerance. Sometimes you will have some little skin reaction to the adhesive in the patch. Another topical is the capsaicin, and this also comes in two forms. The gel, as I said, goes from 0.025 up to 0.075 or 0.1%. And we have the very high concentrated capsaicin, the 8%, which is actually used for post-herpetic neuralgia. The capsaicin cream is used for arthritis and for neuropathic pain. The way it works, the capsaicin, is by depleting substance P. And also, it works on a certain receptor called the TRPV1 or the vanilloid receptors. This is basically here the capsaicin gel. You have the doxepin, which is a TCA, tricyclic antidepressant cream, is used for itching and neuropathy. Doxepin 5%. Also, you have the EMLA cream that we use it for multiple purposes. Lidocaine patch, diclofenac patch, Acutenza, or the capsaicin 8%. The 8% patch, guys, is a very important thing for you to learn because you can use it for post-herpetic neuralgia. And also, you can use it in peripheral neuropathy or intractable peripheral neuropathy. To put this patch on, it burns quite a bit, so you have to put a topical of local anesthetic before you put the patch on, like EMLA cream, for example, and then you put the patch on, okay, because it burns quite a bit, okay. And usually this patch effect lasts for 3 months, so you need to repeat it every 3 months. Capsaicin works on TRPV1. All right, we're gonna jump on the drugs that work on bone pain. The most famous of which are the bisphosphonates. All right, and basically we're talking about the osteoclast inhibitors. But bisphosphonates are pyrophosphates analogs that reduce the bone resorption by causing osteoclast apoptosis, which can prevent the development of bone lesions. This class of medications include pamidronate, zoledronic acid, ibandronate, and clodronate. Evidence shows that these medications are effective in reducing the severity and the frequency of skeletal related events in patients with bone metastases from a variety types of cancer. Side effects of bisphosphonates are esophagitis, flu-like symptoms, symptomatic hypocalcemia, transient renal impairment, severe side effects including osteonecrosis of the jaw and femoral fracture. Bisphosphonates adverse effects: atrial fibrillation, especially with zoledronic acid, osteonecrosis of the jaw, especially with the IV formulation, and atypical femoral fractures. Most common side effects of intravenous bisphosphonates: transient pyrexia, phlebitis at the injection site, transient myalgia and arthralgia, bone pain, malaise, hypocalcemia. Another drug, which is the denosumab, which is basically a receptor activator of nuclear factor kappa B ligand, RANKL therapy. Denosumab is a targeted RANKL inhibitor. that also inhibits bone resorption, but in a different manner than that of bisphosphonates. This medication works by binding to the RANKL and inhibiting it. This causes decreased osteoclast on the bone surfaces. Denosumab can also reduce the frequency and the severity of skeletal related events similar to bisphosphonates. So as you see here, this is the denosumab or Prolia, and it's injected subcutaneously every 6 months. And it works by inhibiting the RANKL, what we call the binding, uh, protein, which is located over the osteoclast. Teriparatide, which is also called in the market for Teo. Okay, it's a form of parathyroid hormone. It's the bioactive portion of the hormone. It is an effective anabolic, and it's indicated in certain cases of osteoporosis, such as postmenopausal women, also in men with primary or hypogonadal osteoporosis, and in treatment of men and women with osteoporosis associated with systemic glucocorticoid therapies. For Teo, this is a subcut injection daily for osteoporosis. Other types of medications for malignant bowel obstruction or MBO, such as anticholinergic medications. These anticholinergic drugs work by decreasing the gut motility and secretions. This medication class includes scopolamine, glycopyrrolate, and hyoscyamine. Literature supports the use of scopolamine as an effective medication for treating pain in the setting of inoperable malignant bowel obstruction. Anticholinergic drugs cross the blood-brain barrier, such as scopolamine and hyoscyamine, have a higher potential to cause side effects, which include constipation, somnolence, and confusion. While glycopyrrolate only minimally crosses the blood-brain barrier because it's a quaternary ammonium compound. Other medications used for malignant bowel obstruction or MBO are the somatostatin analogs. The most famous is octreotide, which is a somatostatin analog that inhibits secretions from the GI tract and pancreas. It also decreases the motility, affecting the aforementioned actions can cause decreased pain as well as other symptoms associated with bowel obstruction and such as nausea and vomiting. The side effects of octreotide are minimal, and the medication has a favorable safety profile. Octreotide can be administered via intermittent subcutaneous boluses or continuous infusion. This is basically glycopyrrolate, and this is octreotide, solution. Um, I use the octreotide usually 100 mics every 8 hours, subcut, but you can use it as an infusion as well. Key learning points. Adjuvant analgesics can be beneficial in many types of pain, either alone or conjunction with opioids. Additional clinical trials are needed in populations with a serious or life-threatening medical condition, but this lack of evidence should not stop clinicians from using adjuvant analgesics as first-line agents. Evidence from available literature in chronic pain can be extrapolated to the palliative care patient population. Consider using these medications as appropriate neuropathic, inflammatory, and bowel obstruction pain, especially in patients whose pain is not responsive to opioids. Thank you for listening, and we'll resume our um, presentation in opioids and anti-inflammatory drugs. Thank you.